So my name is Tamar Austin, and I would like to humbly and respectfully acknowledge the land on which I and the Birthplace Lab currently reside is the unceded, stolen, traditional territory of the Coast Salish peoples, including the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I'm especially grateful to be a guest on this land as someone whose family originally immigrated from the Caribbean. My ancestors have been displaced there after they were stolen from their own lands. As we gather here today, we honor and recognize the importance of sovereign birth and the traditional birthing practices of the peoples whose lands we currently reside. We commit to make space for and support the holders of traditional birthing knowledge who have remained steadfast in their practice despite the best efforts of colonialism and white supremacy. It's our obligation to continue to be the proponents of reproductive and birth justice, especially in the face of deeply entrenched inequities. I would also like to invite everyone to share the traditional lands on which they currently reside, as well as their names, position, and organization they are currently a part of. While you're doing that, I want to introduce to everyone Manavi Handa, who will be speaking on the challenges and barriers to perinatal care for undocumented and uninsured refugees in the Canadian context. Manavi Handa is a registered midwife and faculty member at Toronto Metropolitan University. For more than 2 decades, her research, activism, and clinical work have been focused on care for documented and undocumented refugees. Notably, her research was foundational in increased Ministry of Health funding for midwives caring for uninsured pregnant people. Manavi's social and reproductive justice work has been recognized through the Urban Alliance for Race Relations Awards, the Iweroquois Cape Award for Midwifery Heroes, and most recently, the Planned Parenthood Reproductive Choice Award. Manavi currently works in an expanded scope model through West End Midwives. During the presentation, we request that you please keep your mics off in consideration of our speaker and other attendees. Additionally, we ask that you please hold your questions for the end of the presentation. The presentation will be recorded, but the discussion section will not in order to support free discussion. On that note, I'm going to hand it over to our speaker, Manavi Handa.
Hi, and thank you so much for having me. It is a pleasure, and I'm very humbled to be here. Okay, so I'm going to be talking today about undocumented refugees and perinatal care, some of the challenges that we're seeing both in Toronto and that are kind of replicated across the country, and even in other what they call high immigrant receiving countries. We'll talk about that a little bit. And then I'm going to talk about some strategies we've used in Ontario that have been quite successful and how they might be replicated in other areas. So, and if anybody has any questions, my email address is on the first slide. You're always welcome to get in touch with me. So we're just going to give a bit of background about what it is to be an uninsured or undocumented refugee, talk about the importance of prenatal care, some of the impacts of inadequate access to care that we're seeing, and then the Ontario example with a very short overview of the research that kind of led to increased funding. So just for a little bit of background, the issue of undocumented refugees, and I use the term refugee very deliberately, having worked with this population for over 2 decades, really we are talking about the world's most marginalized when we're talking about people who are undocumented, and I'll get into that a little bit more. So this issue, interestingly, was very much centralized to urban centers like Vancouver, Montreal, Toronto. We are definitely seeing it spread as cost of living in cities is just less possible for people. So definitely we're seeing it, in sprawling suburban areas and smaller communities where people are moving. The magnitude of the problem is actually unknown. How many undocumented people live here? And when I say undocumented, I'm mostly talking about undocumented refugees, but how many people live in Canada or Ontario who knows? The most recent estimations are about 500,000 in Toronto, 1 to 2 million nationally. The lowest estimate is 500,000 nationally. And I thought it would be interesting just to do a little bit of math. So the global population right now is about 8.1 billion. There's 108 million displaced people in the world, according to the UN. That's 1 in 75 people. 1 in 75 Canadians is 510,000 people. So we, at minimum, have our share of the global displaced population. And my guess is we probably have more because we are a quote unquote high immigrant receiving country and a country with wealth and opportunity. So there have always been people who are uninsured or undocumented. Historically, this was people without identification. So people living at the intersections of street living, mental health, addictions, at those intersectionalities. And also, we have always had obstetrical tourists or medical tourists, as they're called. The global elite have always traveled the world for healthcare, and I don't actually think that's going to change. Where it is a bit of a red herring is this idea that we have thousands of people coming here just to have a baby and to use our healthcare system. Certainly in my experience, part of being global elite is the cred of paying for care. Many people talk about it being a red herring. And what I would say is, if there is an issue with obstetrical tourists coming here, then that's an immigration problem. We can't then impact marginalized people because we have wealthy people who are using the system, which I don't even think we have that many, and nor does anyone else. Like, research really shows that we're not talking about wealthy people. We are actually talking about very marginalized people. So who are the newly uninsured? Interestingly, permanent residents, especially specifically in BC, Ontario, and Quebec, used to have to wait 3 months before they got health insurance. That has paused since COVID. That's one of the 3-month wait seems to be one of the things they haven't reinstated. And just for people who don't know, during COVID, very quickly during the pandemic in Ontario, the government put measures in place so that anybody had access to healthcare, which was very interesting. It was an open admission that we have many people living in our borders who don't have access to healthcare. And it was an open recognition that the health of everybody is interdependent. And so very quickly, all of a sudden, it was possible to give people healthcare for free, and it didn't bankrupt our system. And we did it at a point when our healthcare system was already stressed. So that also showed actually providing healthcare takes stress off the system versus when you don't provide healthcare and people use the system anyway, but when they're much sicker. Aside from the 3-month wait, there are also what I would say a fairly large number of rejected or failed refugee claimants. And that we're seeing larger and larger populations of that. And then we have the truly undocumented. So these are people who have expired visa, failed claimants, they don't have status. Basically, less than half of the people who apply for refugee status in Canada are granted refugee status. I can tell you from working on the ground, as I think most people in agencies would say, those who don't get status don't go back home. That's not an option. People who are willing to live here without status are leaving bad enough conditions that they're willing to live here without status, which is not an easy life. I really like the term. So many people use the term precarious immigration status, and that's also because we have many more people moving between categories and waiting years for applications to go through. And so we have people, for example, you might have a student visa, you're eligible to apply for a work visa for a year and then permanent residency, but you might go years in between the student visa and the permanent residency, and so fall out of status. I really like the term illegalized because we're talking about people who our system is making illegal. These are not people who want to be living here illegally. And really what's important, I say this is a newer issue, newer meaning the last 20 years, and really kind of at massive proportions now. There are very few systemic responses because Canada still doesn't acknowledge that this is an issue. And so you end up with a lot of stress on healthcare and social services. We're really seeing that play out around the shelter system right now, where asylum seekers are the people who are being denied in the Toronto context and the Ontario context, even though Toronto is supposed to be a sanctuary city. So it shouldn't matter what your status is if you are accessing a shelter. And we very sadly had someone recently who died living on the streets, who's an asylum seeker, trying to get shelter, denied care in the shelter service in Toronto. So this is a situation that's really growing. So the political context, as I talked about a little bit, there are many more changes to immigration policies, and we have many more categories of immigration than we used to. So we end up with people who are stuck in between. We have fewer refugee claimants that are accepted. So we think of ourselves as a very high refugee receiving country. And, in some ways we are, in some ways we really aren't. Our numbers of the refugees we accept are much lower than they were in the 70s. With increasing global health and economic disparity, I think you can close your borders as much as you want. We're seeing this play out all over the world. We're not going to stop people from coming into a country that offers some level of safety. It's also more difficult for some groups to go through legitimate channels, especially in, the era of terror, the last 20 years that we've been living through. And this is very similar in high immigrant receiving countries. They're all grappling with this. What do we do with pregnant women who don't have status? And they're all dealing with this issue of more and more people without status. I think, this is also, to me, it's a little bit of just colonial karma. There's a great talk, this little comedy bit where someone is talking about why there's so many immigrants in England, and it's by Trevor Noah, and he's like, because you went around the world and told everybody about England. He was like, we didn't know about your island. And so, if you have 500 years of taking wealth and land and having all of the opportunity and selling the idea that the West is the place to be, guess what? That's where people are going to want to be. So the numbers are dramatically increasing, and I think they will just continue to. What does research tell us about people who are undocumented? There's a recent article that just came out that shows that immigration status is actually the most important social determinant of health. Undocumented people are the most vulnerable to mistreatment in the workplace. They don't have access to social services, vulnerable to mistreatment with housing, and many other things. Pregnant women and newborns are disproportionately impacted. And I'm using gendered language here on purpose because this is a gendered issue. We know that people who are undocumented have poorer access to healthcare. And this includes children who are eligible of people who are undocumented. And we're talking about people who are much more likely to be from racialized communities. What does research tell us if you are undocumented and pregnant? That there's poor health in general, which is interesting. That's different than the healthy immigrant effect, which often shows in early years that people are healthier. And this is probably because it's people who've been living here for a number of years without status, or who are coming from very difficult situations. There's much higher incidence of psychiatric disorders, especially depression and anxiety, and much lower seeking of healthcare for these psychological issues. There's increased vulnerability to intimate partner violence. And I really want to make this clear. It doesn't mean there is more intimate partner violence. It means when there is intimate partner violence, the threat of deportation is part of that violence. And we have to remember that women are much more likely to be here as sponsored immigrants. We favor business class immigrants and people with certain amounts of money, and that globally tends to be men. So basically, people who are uninsured and pregnant get inadequate prenatal care and care later in pregnancy. So why this? Oh, and I just wanted to quickly show, this is from the article showing that immigration is the most important social determinant of health. I love this graphic. I'm not going to go into it, but I want to show the immediate, my little red dots there. I'm very bad at free writing things with markers on PowerPoint, but fear of deportation, limited access to health and social services, poor living conditions, and healthcare avoidance. So imagine all of that with people who are pregnant. There is a really indisputable relationship between prenatal care and improved outcomes. We don't understand why, and we don't necessarily know how much prenatal care is the gold standard, but we know that no prenatal care or limited prenatal care results specifically in much higher rates of low birth weight infants and preterm labor. And the data that I'm using, these numbers of ×4 and ×7, is specifically from the United States, because that's where they have data about people who are uninsured. And it's important to remember that babies that are too small and too early tend to be among the highest of all of our healthcare expenditures, babies in the NICU and premature babies, and also tend to have lifelong consequences. So we're talking about people who are already impoverished, marginalized, racialized, and are more likely to have quote unquote Canadian children who are less healthy. So there's a really, in terms of government advocacy, there's a really compelling bottom line argument. Every $1 in prenatal care is $2 to $3 in healthcare savings. This is kind of old US data, and that's because there isn't so much on the costs of prenatal care in recent years. And this is just a very brief overview of what it's like to try to navigate healthcare when you are undocumented and a refugee. So you can try a walk-in clinic. They might send you for an ultrasound, but they're not going to do ongoing care. You can try to get primary care, but no one's going to take you because you can't pay them. So you try to go to a family doc. Most family docs aren't doing prenatal care. They'll refer you to an OB. An OB will take a massive amount of a retainer fee in order for you to even get a visit. If you're lucky, you might end up with a midwife, but 40% of people wanting a midwife in Ontario can't get one. Or if you're lucky, you end up with a community health center. They also turn away many, many people because they don't have capacity. So you end up getting care later in pregnancy and less or no prenatal care. And I would say often piecemeal care. Like I was worried, I went to the ER, I have one report from there. I went to a walk-in, I have another report from there. I paid for my own ultrasound, I have a report from there. But definitely not coherent care. These are the practicalities. And, this is a pre-COVID slide. Post-COVID, certainly in Ontario, there's a massive push to try to regularize funding and also for hospitals to really, really slam the door in these people's faces. So we're having both things happen at the same time. The jury's kind of out on where costs are going to end up. But if you're lucky, a low-risk pregnancy is going to cost you about $10,000. This is pre-COVID. But this was from a very well-known downtown Toronto hospital, and $15,692 is what is required upfront before you can even get an appointment with a perinatal care provider at that hospital. And that's what hospitals all over Ontario are doing, and I am hearing kind of across the country similar things. This is just a bit of an overview. I'm just doing a time check. Okay. A bit of an overview of, so one of the things I do is I run a clinic through a community health center. They have a walk-in clinic, and I see all of the pregnant people there. This clinic's been running for 10 years. It's the longest standing clinic, certainly the only midwifery access clinic for walk-ins who are undocumented in Toronto. And one of the only clinics where you can walk in and get care in pregnancy in the country if you're undocumented and don't have insurance. We did a study. We've just collected 10 years of data, but we haven't gone through it yet. But we did a study for the first 3 years of the clinic, just to give you a snapshot of who we're seeing. More than 60% of the people we saw had an annual household income of less than $20,000. Many people were from the Caribbean, Central or South America. I find this very funny. It's when I was working with Syrian refugees that I had this epiphany moment where I was like, oh, there's no great love between Syria and Greece. You can just get there. And really, that's why this is the group of people we see. It's people without a lot of means who can still get this far. Whereas if you're coming from Nigeria, there's a lot more barriers, including the plane ticket cost to get here. Average gestational age at first visit was 16 weeks, which is well beyond first trimester, where we often offer genetic tests and other important tests. 33% presented after 20 weeks. And I should say the latest person presented at 43 weeks and basically was sent to the hospital for induction. I just have to say this, this client had 3 classical sections and kept showing up to the hospital saying, I've never gone this far in my pregnancy, kept getting turned away saying, come back in labor, because she didn't have money. Everybody involved in that knowing this woman would have potentially died if she labored. So I shouldn't say she went in for induction, she went in for a section. And that also speaks to the fact that nobody's claiming this issue. People go from one hospital to another, and everyone just washes their hands of any emergency that happens. 28% were single parent homes. And for people who were failed refugee claimants, it was 42%. So I want you to remember that sponsored immigrant threat of deportation demographic. We are talking about people who are partnered with Canadians who then have a bad relationship situation, get pregnant, and have their sponsorship dropped. So they're here and pregnant and don't have status. A reminder of what these costs are. So think of those demographics. How is anybody paying for this? So what's happening is you're not paying and you're just not getting care, or you're going when it's urgent. I'm not going to do my story time, but I did do that little short story. So just to give you, I'm going to just do a 5-minute snapshot of our funding. And if people want more information and want to actually meet to talk about how to implement something like this in their own region, I'm happy to do that. So really before 2015, and what the rest of Canada is kind of dealing with, is that midwives we're paid to care for uninsured clients, but there was no funding in place for consults or transfers or diagnostic tests. That all had to come out of the client pocket. So we would get paid, but the client still had to dish out a lot of money. Or what's happening in other jurisdictions like BC, midwives are not paid for uninsured clients, but they sometimes will take clients pro bono or for minimal payment. And again, there's no funding in place for consultations, transfers of care. So the impact of this is, one, you have midwives who are taking these clients and are taking, making that choice. Then there's an emergency and you show up and you're like, physician, can you deal with this problem? You're probably not going to get paid. And this physician's getting pulled into this situation not by their choice. They didn't choose this client. And whether we think they should choose the client or not, that doesn't make people happy. There's a lot of medical legal risk in obstetrics. The jury is out with the CMPA as to whether physicians will be covered for people who are undocumented. Midwives are generally newer to the healthcare system, so it's not that people are jumping up and down to have us around anyway. So then you're showing up with people who are undocumented, and the physician's not likely to get paid, and the hospital's not likely to get paid. It doesn't lead to people being happy. And I have to be clear, our political system does not support uninsured or undocumented refugees, and hospitals are very much about mainstream politics. The impact on clients is even worse. So midwives are reluctant to provide care. They're reluctant to transfer because they're worried that the consultant's going to yell at them. So you kind of transfer later than you might otherwise. It's poor professional behavior, just terrible racism at the bedside, atrocious behavior, bartering with clients for epidurals and how much money they have. And like I've seen doctors bartering for someone's gold bangles because the woman didn't have any cash for an epidural, like really bad behavior. And I do want to say people deserve to get paid for providing care. That is our system. Many clients not getting tests because they couldn't deal with costs, or not being able to follow up with maternal fetal medicine follow-up or diabetes follow-up. And really, like, no systemic solution. So you see that at every level. The individual providers are burnt out. Institutions are pissed off because they're like, we deal with this more because we have a high immigrant population. And you even see it between tertiary care centers who are like, we don't want these clients here. Tertiary care is very expensive. Lots of systemic racism. And I would say like the NIMBY syndrome. So not in my backyard, every hospital trying to get these people to go to another hospital. I think we're seeing that all over the place. It's really interesting who is made illegal in this country. It's not people from Western or Northern Europe. Those people are getting visas and status. This is a very colonization legacy, and I think it's important for us to look at it that way, that the privileged few from the world's poorest countries are allowed to be legal, so the global elite, and those from colonizing countries. But poor people from poor countries, unless we're taking them in as one of the rare refugees, they're not getting in legally, and yet they have very little to go back to. And then I talked a little bit about COVID. What was important also about COVID is we realized that a lot of undocumented people are actually essential workers. I don't love that argument because people shouldn't be valued for their ability to work, but we're not talking about people who are using the system. Okay, so I'm going to just quickly talk about what happened in 2015. I did a study, and really I was working with a community health center that was covering the consultation costs for our clients. And I was trying to say to them, you guys are referring everyone to OBs, even low risk. It makes more sense to refer the low risk people to midwives and the high risk people to OBs. You'll stretch your money out. It'll be cheaper. And I realized we all thought common sense wise, it would make sense. It's cheaper because if they're sending someone to a midwife, they're not paying the midwife anything. They're only paying if there's a consult or a transfer. So I did a chart review of 200 patients and looked at their care with a midwife and exactly what that care would have cost if it was with a physician. So how much would the prenatal visits have cost? How much would the delivery have cost? I didn't add premiums for weekends and nights, which we know is a huge, huge proportion of what people bill. And even then, basically the offshoot was, it was the first time we had, what does it actually cost extra for low risk uninsured clients who become high risk? Like if we were to take care of all of these clients, how much would it cost us? So what was really beneficial about actually having this is what it would cost is the Ministry of Health got word of this study and asked me to present it and basically present a business case for why they should fund midwives directly for consultations and transfers of care and diagnostic tests. So since 2015, now when we have an uninsured client, everything is covered. If that person has 2 surgeries, it's covered. If that person has 14 consults, it's covered. And really, I think that's what we've been able to do, at least, it's not covered for everyone, but at least in midwifery, we've been allowed to make that argument. So the numbers themselves are a bit old, and they're not important other than to know what's important for government is that you have numbers. And I'm happy to talk to people about how to replicate those numbers. And I think now that we have a template, it's a replicable model in other places. I think it's also important to know that you can say there's a successful funding model in place. What's great is since 2015, funding for uninsured clients is now part of our government contract. So it can't really be taken away. I mean, anything can get taken away with government contracts, but it's not something that we're bargaining for every single time. Yeah, I think I'll probably wrap it up there and open it up to questions, because I think that might be where people get more useful information. Although I do have a great story about how the funding happened. Okay, maybe I'll take 2 minutes and tell that story first. So I find this fascinating. So it's just fascinating to know how government decisions get made. So I do this study and I'm like getting ready to be like, okay, I'm going to present it to a bunch of community health centers. A colleague of mine who knew the work I had done with uninsured and knew about the study was working as a consultant with the Ministry of Health. So she mentioned it, and it just so happened, and it was interesting. Things with midwives and the government weren't necessarily great at that time. And in some ways, it was a strategic moment to advocate for this, because they were like, well, we're not giving you other stuff, but look what we did give you. So it's also interesting to know that you can kind of leverage not great moments sometimes. But there was someone in government who had worked with immigrants in their previous government life, and realized that there were lots of barriers to care, had worked with community health centers. So, and was kind of a bigwig at the time, is now retired, which is why I feel okay telling the story. So I got invited to present to the Ministry of Health a proposal for how they could fund uninsured clients and why they should in midwifery care. And it was interesting. It was very secret. I wasn't allowed to tell anyone. I had to go through all kinds of security going through. I had to leave my cell phone. It was very surreal. I give this presentation, and this guy I don't know, but who's the one who's extended this invitation, is sitting in the back of the room, and he's kind of nodding his head. And then he sits and he's like doing calculations. He's like, okay, 2 million, 1.3, $1.5 million, probably. Yeah, sure, done. And I was like, okay. And I was like, what does that mean? And who are you? Wait, I leave the meeting. I'm not allowed to tell anybody that I've had this meeting. And then I never hear anything again. And I was like, that was such a weird experience. About 10 months later, when they were negotiating, the Association of Midwives of Ontario sent me an email and said, the government decided they're going to fund uninsured clients, and we don't know where they got these numbers from. And it was that slide that I had just showed with my numbers. And I was like, oh, and really, once I gave them the presentation, they were like, we own this. I'm now telling the story because it's been a number of years, it's in our contract, but I did think, like, what a fascinating way for such an impactful political decision to have happened. And it was because there was one person in the ministry who kind of championed it. Okay, now we can open for questions.
Thank you. That was great. So thank you to Manavi. That was extremely informative and just more and more relevant based on the current Canadian context.